Good morning again, everyone, and welcome to MPHA's annual conference. We are excited to start our second session of the day, bringing COVID testing home, how community organizations are driving community testing. Before I introduce our speakers, just a few reminders, which if you've been with us for the past 2 days, you probably know these already, but we are offering closed captioning, which you can see underneath your video. If you don't need it, you can always hit the pause button. Please remember to provide feedback and complete the evaluation by hitting the feedback button at the top right of your screen. We will also be taking questions at the end of this presentation, so please use the Q&A feature to enter in any questions you have for our speakers. As a reminder, again, the challenge is closing at 3:30 and our closing remarks will start at 3:50, and those you can stay right in the last session to be there for those. But I'm excited to announce 3 speakers for this morning's session. We have Carla Hunt, coordinator with the DHHS's COVID social support, Hibo Omer, program director for the New Mainers Public Health Initiative, and Abbie Yamamoto, the executive director of the Maine Association for New Americans, and they'll be talking with us about their work on bringing COVID testing home. So I will turn it over to the 3 of you to begin your presentation. Thank you.
Thank you. Good morning, everyone. My name is Hibo Omer, and today we will be discussing about bringing COVID testing home, how community organizations are driving community testing. Next. So just a disclosure, the presenters have nothing to disclose with regards to commercial relationships. Next. So what is community? We will discuss specifically what is community testing and why community testing is needed, how to community test, and in conclusion, we will talk about lowering the barriers and blurring the lines. Next. So when we say what is community testing, it's testing the community not in a medical or clinical setting, but rather testing at a site of everyday life. For example, like home, workplace, school, site of communal gathering and entertainment, and having a community-specific focus of outreach. Next, Carla.
Thank you, Hibo. I'm Carla Hunt, and as Heather mentioned, I'm a member of the DHHS COVID social support team and also the Yarmouth Community Coronavirus Task Force. So when we talk about why community testing, we are really thinking about the fact that community testing is meant to address gaps in availability and concerns about inequities. Putting testing in the hands of community organizations opens the door for more testing, for more education, for informal contact tracing, and for prevention. Our testing teams work collaboratively with the state of Maine, offering both antigen and PCR testing, and those results are officially reported to the Maine CDC. The teams are fully trained to administer both tests and are CLIA certified to report results. With immediate results, testers provide immediate and vital information to their community members, such as how to quarantine and isolate, how to prevent the spread of COVID, symptoms to look for as close contacts, how to reach out for additional testing, and they offer social supports in the form of food, rent relief, shelter, masks, thermometers and other supplies, and stress management counseling. Testing is so much more than the test itself. Next. Since May of 2021, 21 organizations and over 60 people have been trained to offer testing in their communities. 18 of these organizations serve non-native English communities, English-speaking communities, whose first languages are Somali, Lingala, Spanish, Kinyarwanda, Kirundi, Arabic, and Japanese. Oftentimes, those being tested are fluent English speakers, but they prefer and appreciate the cultural aspect of having someone from their community or region providing the testing. This aspect takes testing out of the paradigm of professionals using interpreters and cultural brokers to provide services and putting testing in the hands of trusted community members who can explain why testing is important in their own words without mediation. Coverage extends north to Penobscot County, south to York County, and points in between. We recognize that there are still pockets of populations where testing is not accessible, and we're working to improve that. 70% of those tested are non-native English speakers, a much higher level than what state testing sites are seeing. Next.
Why community outreach testing is important? Well, bringing testing home, when it takes the medical profession, it takes the testing is taken from the realm of the medical profession into the hands of the community members who can describe the why to the community and result in testing. And it humanizes the clinical process of the testing, providing a more communal centered and have a space of outreach. Carla.
So thinking about how home testing came to be takes us to Shebig Island off the coast of Yarmouth. Shebig is isolated from the mainland by water. And at the start of the pandemic, town leaders worried about their ability to provide testing to their own members, to their own community members. They stood up their own testing site and partnered with the state to get samples resulted through the state Hibo lab. Then they shared their stories and lessons with the town of Yarmouth, the town where their ferry lands. The Yarmouth Community Coronavirus Task Force also worried that people living in isolation right in the middle of our very affluent town also did not have access to testing. Perhaps they did not have a car to use for drive-through testing sites, or they were not familiar with how to register for an online appointment, or they weren't comfortable speaking or reading English, or they just didn't feel comfortable going out to places that weren't familiar. Yarmouth took the lessons from Shebig and stood up its own testing group and was then called on to test beyond Yarmouth and into Lewiston and Portland. We soon realized that training other communities to test would increase the number of people being tested. And through DHHS, tester trainings took place throughout the summer and continue today. Not only are community-based organizations identifying people in need of testing, but DHHS calls on these same teams to go to other communities to test. In this way, these teams have expanded their reach beyond their own communities, and they play a key role in ensuring that home testing is available to all Mainers. Tests are administered when someone is symptomatic, when they are a close contact, for school purposes, or when a person simply needs to know their status. Testing is becoming normalized. Next. These are images of some of the testing teams that have been trained. They represent the Lewiston area, Portland, and Biddeford. Next.
And New Mainers Public Health Initiative is one of the community center that does the testing. And at the beginning of COVID last year, LA Task Force, Lewiston Auburn Task Force was formed. And because many of the immigrant community had a concept of when the swab is being done through the nose, it will touch the brain. So as LA Task Force members, that was combined of 12 agencies, we thought that we have to create something and think outside of the box to reach the community with videos in specific languages such as Somali and other language spoken in the immigrant community, and also interviewing foreign-born doctors so that they can hear from them in their own languages. And we created role plays where we talked about the myth and the fact as well. And out of that also came a week of action where each agency went door to door and did outreach through the community to come out and test. Next. And out of that action week, we did tabling where tables were placed in where people always walk by in Lewiston area. And at the same time, going to apartment buildings and knocking at the doors so that people can come out on a Saturday from 12 to 5 so they can be tested. Next. And when that day came of testing, a lot of people came out. And because there were previously a lot of groundwork done, 64 people were tested. And out of that, one provider disclosed that the last 3 months, only 70 new Mainers were tested. So at least at the end of all that hard work, it was possible to kind of, the outreach worked in a sense, and the proof was in the pudding. Next.
Hi, my name is Abbie Yamamoto, and I'm the Executive Director of MANA, or Maine Association for New Americans. We were founded by asylum seekers in 2012, and our mission is to build resilience through connections. So it's important to us to create safe spaces where people can engage in dialogue, but also to bring ourselves to engage not only with our own communities, but within the larger community that we live in. So to embody that, we run 2 projects. One is running peer support groups, and the other is our COVID-19 response project, which came out of the pandemic. And this includes bringing COVID PCR and antigen testing to people's homes. And this is what I'm going to focus on today. And we do this in collaboration with other community-based organizations and community action project agencies, CAP agencies, and DHHS social supports. And as a way of introduction to our project, COVID-19 response project, I want to explain these photographs. The one on the left shows our training to use the antigen test, and the one on the right shows the van, one of the vans that we've used to transport over 200 people to quarantine shelters, vaccination sites, and to bring mobile PCR and rapid testing to almost 300 people in York County to the south, and to Jonesport east of Bangor to the north. The 2 main populations we work most frequently with are members of the Central African communities, including the Rwandan, Burundis, and Congolese communities, and those from low-income households who are connected with social service agencies. In our work, we've identified 5 elements to conduct successful community testing. And those are: 1, convenience. So we go to people's homes so they don't need to leave their homes. And if they don't have a car, which is a problem with drive-through testing, that's also not an issue. And also another thing that we've done to increase convenience is that we created an online form to fill out the necessary information for reporting the test results to the state. And this allowed us to front load the administrative process of testing so that when we show up for testing, we could just focus on the testing and the talking to the people side of things. And it also made the process more efficient and reduce the likelihood of introducing errors in the process of creating the test forms. Next is availability. So we run 7 days a week from 9 a.m. to 7 p.m. during the week and 9 a.m. to 5 p.m. On the weekends. And this 7-day availability we felt was pretty important because that makes us available. It's only into early evenings, but evenings and also the weekends And for many immigrants, they work very long hours and often multiple jobs. So the flexibility in schedule we felt was important. Next is familiarity of the people providing the service. And this really, like Hibo was saying, it really showed up in the way we get the testing referrals. Of course, there's the DHHS referrals too, but also our testing requests comes from community members of the staff and board members. And the shared cultural and linguistic background and our perceived similarity definitely helps. But it's also about just sharing the same social circles. And so we get a lot of requests from people who are within the same social circles as ourselves and also board members, but who we don't necessarily know directly. And that really is a strength of, and the purpose, I think, of community testing. And last 2 points are flexibility and patience. So the flexibility being, of course, that we're able to adjust to sudden changes in schedules, but really it's combined with patience in the sense that we're going into sites of everyday living, which means that we're not the priority, like when people go to a doctor's office or clinic. So one, it takes a lot less time for them to get tested, but it also requires flexibility and patience on our end to be able to adjust to little schedule changes that are going to creep in to the 2-hour appointments that we made. And so that is a point that we try to keep in mind is as we work with people. Okay. So in summary of sort of what Hibo and I were talking about, and also sort of to connect to a larger point that we'll talk about next steps, it's really important that we lower the barriers and blur the lines in order to spread testing out into the communities. And some of the ways that we lower barriers is by making the testing readily available, and also conducting grassroots outreach that are done by community members. And so it's done by familiar faces, and it doesn't have a sense of divide that that's a special clinical space that we're going into, but that it's integrated into people's lives. And then blurring the lines is also another way to put it, in that this is about expanding testers to also non-medical professionals. And so this is one of the ways in which the lines get blurred, and also expanding the sites of testing to include non-medical settings, including communal sites of everyday life. And this helps to normalize the testing experience.
So there are many implications for the future based on this experience that we've had around testing. We're learning just how valuable community-based organizations are to the entire process of an equitable health system. Having the input from community-based organizations, not just in the delivery of health services, but more importantly, in the planning of health services, is essential to reaching all Maine residents. A full and equal partnership with communities of color and rural communities leads to more equitable access. Next. We see opportunities beyond COVID for these partnerships to continue and flourish as we continue to address basic health needs. We know that creating sustainable systems is, in one example is this COVID testing process, but creating more sustainable systems to collaborate with grassroots and community-based organizations is key. We continually look for ways to build change agents that can identify the gaps in our current system and address these gaps as we move forward. Hibo and Abbie, I don't know if you have anything else to add. All right, well, thank you for participating. Our contact information is below. Thank you.
Thank you all so much. That was a great presentation, and you're doing amazing work in your communities to increase testing rates. Just a reminder to folks, if you have questions for our presenters, to please put those in the Q&A, and we will take them. We have had a couple come in so far. So one, this is such an undertaking. How have you recruited people to help with the testing sites? So basically, how are you staffing all of these sites?
I'll let the others speak, but I will say from a coordinating standpoint, that has been the easy part. There has not been a lack of volunteers or community workers willing to take this on. Hibo can provide some more information about that.
Yeah, thank you, Carla. What is it? Yeah, we have usually CHWs, community health workers on board. So when the referrals come in, we have it's staffing. Thus far, staffing is not a problem. Let me put it that way, because people really step up to the plate, and they we have close to 13 CHWs now. So doing social and emotional support, social services, vaccine education, at the same time testing as well. So, and everyone in our staff is trained except few who are just newcomers. And even we are teaching, we are giving the training to the front, the office assistant as well, so that we don't have to worry about no one knowing the testing. Anything you want to add, Abbie?
Yeah, I think that generally there are always people who are very motivated within communities to make sure that the spread doesn't happen. And particularly, I find that people who are in leadership positions within each of the communities have high desire to keep their communities safe. And so it's just about identifying those people and working with them. And people are willing to work voluntarily. I feel like compensating people properly for the work that they do is critical in order to keep it sustainable, because that part of the reason why so many immigrants work so many jobs is because the jobs they have are so low paying, and they just can't sustain their lives. And, you know, and community service is real work. Including emotional labor of supporting each other through very difficult things. And I feel that compensating that work is critical. And so I focused a lot on being able to compensate people well in the work that they already do, and also work that's an extension of what they're already doing. And so that's also, I think, important in considering about identifying the people. Like Carla says, I haven't found that to be the difficult part. It's just more about making sure you create an equitable environment where we can all work together fairly.
Thank you for that response. And I'm really glad you mentioned compensating people for their work. We've had some other conversations throughout the conference and comments coming in through the chat about the need to compensate. So thank you again for bringing that up. Ibu, you mentioned this, alluded to this in your answer about providing information on vaccination during the testing. So can you talk a little bit more, and Carla and Abbie as well, about how you're providing this and what type of education you're providing?
Yes, mostly, you know, when we go to testing, we also, within the questionnaire of the testing, there are two questions, if I'm correct, if the person is vaccinated, and then that opens up if the person is vaccinated or not. And then if it is, then, you know, that's good. But then if it's not, it gives us an opportunity to educate the person of why not vaccinated. And because it's one-on-one, there is no intimidation as well. People open up and they will tell you why they're not vaccinated, and, you know, the reason, the whole truth. And that kind of gives us an opportunity, rather than, you know, pointing the finger at them, gives us a chance to educate them that, you know, the person, all our staffs are vaccinated. So we try to tell them, I'm vaccinated, yeah, and not everyone gets sick. And why, you know, the reasons. Some people will say, well, everyone who gets vaccinated, it gets sick. And, you know, that's not true. We were waiting. I you know, we humanize it. And we, you know, personally, I was waiting to get sick and I didn't, and I have to literally research why I didn't get sick. And then, heaven behold, I found out that half of the people were sick, only half didn't get sick. And that kind of, it was mind-boggling, because I heard it so many times that I internalized it. And I tell them that, I was waiting to get sick, but not everyone gets sick. And that's the reality, where always the negativity, is spread faster than the positive. And that also gives them to think a second time. And it's really a good opportunity. Anyone, Abbie or Carla, you want to add something?
Yeah, so I'll just say that the Asian community actually has the highest vaccination rate in the state. And so it's not my community that I talk to about that. I mostly hear about it from our team members who come from communities where vaccination rate struggles a little bit. And what I hear consistently from board members and team members is that really, there are memes and there's flyers. And so we do create those informational materials too, with flyers and videos and stuff, but that's really, it has to be always combined with then a one-on-one conversation with either a friend or someone who's in the same social circle as you. So it's a combination of these informational materials that are just mass distributed and that are not individualized. And then it's the series of one-on-one conversations with different people, and then seeing the social proof in people who they know also in the same social circles who did get vaccinated, and having that be right in front of them as reality. And it seems like those are the three things, if they're not the population that was banging down the door waiting for the vaccination, which there are definitely people that like that too, but currently in the more hesitant group, it's the combination of those three things together have to be put into place to change their minds, to be finally convinced to get vaccinated. And then another thing that's really important is to catch them in the moment that they're like, okay, maybe, when they're relenting a little bit, right? Because that when you don't do that, then you kind of miss that window of opportunity sometimes. You're usually not permanently changing people's minds, you're kind of temporarily changing people's minds. So you got to get right in there and say, okay, you want to do it right now? I know a place I can take you to, and get them vaccinated. That's how we find that we get vaccinated people.
The only thing I would add to that is the degree of creativity that's coming through community-based organizations to help them test and get vaccinated is astounding. Oftentimes, vaccine clinics and testing clinics are held at the same time. The other point I wanted to make is that this has created pathways to help communities get vaccinated for other means, like for other reasons. For instance, the flu vaccine, or the vaccines that children are going to have to eventually be required. So this has been a wonderful way to enter communities and to encourage them to get vaccinated for a number of different reasons.
Thank you. And I'm glad you answered that. That was also one of the things I had been wondering, is if this related to other vaccines. And I think you make, wonderful points that we have to reach people where we are, provide them with different types of information, and really the importance of that one-on-one and relationship building. I think we have time for one more quick question. I don't know if it'll be a quick answer, but is this project working at all with case investigation and contact tracing?
Definitely that's the case. I will let Hibo speak first. I'll go next.
Okay. Yeah, sometimes, thank you, Carla. Sometimes ethnic-based organizations find people who have a positive and refuse to talk to DHHS. So the referral comes from downstream and upstream, I guess, because usually we find people so that we can send out to DHHS and then do the social service and things like that. So it's a two-way that's really happening. And within that, on the ground, what I see is that a lot of people will say, well, I was also with so-and-so, and they open up honestly, and we have we capture more people on the ground when people self-refer and come to us, then it's from the top, so to speak. So it's kind of, it is opening up a lot. And we found a lot of cases that would have went through the crack as ethnic-based organizations.
I'll just add that CDC is committed to working with community partners for contact tracing and for case investigation. Oftentimes, the people who are administering the test are also able to work with CDC on those aspects. And so there's a partnership that's forming that helps make that process a little more effective.
Thank you both. And unfortunately, we are at time. I always hate to have to play this role, but I want to thank the three of you for being here this morning and sharing your work. And hopefully we can continue this conversation, and we will as part of the conference. Our next session is on equitable vaccine distribution in a pandemic, starting at 10:20. So just a reminder to please complete the evaluation by using the feedback button for this session. Thank you to Carla, Hibo, and Abbie. You all are doing fabulous work, so we appreciate it. And we will see everyone back here in about 8 minutes at 10:20. Thank you.
Thank you.